for joining us today. I welcome you to this new webinar on inequities in digital health, part of a speaker series that we have created at UNITAR, the United Nations Institute for Training and Research, out of Geneva. We are in our headquarters at the Palais des Nations in Switzerland, and it is quite a privilege to be able to engage with all of you around the world. My name is Alex Mejia. I am a division director here. I have the privilege of working with Dr. Danny Sheep, who is the lead person on our new digital health initiative. Danny brings an impressive array of skills and a very sound experience to guide this new project that we have recently launched in cooperation with several partners. But as important as that, I would like to mention also in advance that we will have the privilege of listening from Dr. Alessandro Vlasime, a senior researcher on health ethics and policy lab at ETH Zurich, the famous university here in Switzerland. Now, in order to provide a short introduction, I would like you to allow me to perhaps link what we are going to do today with this new part of our identity at the United Nations. We had launched in September of 2015 the Agenda 2030 for Sustainable Development and its Sustainable Development Goals. As part of this new agenda, something that was following on the initial experiment, for lack of a better description, called the Millennium Development Goals. So the second phase of a global roadmap towards sustainable development and the fight against poverty and better standards of living and the protection of the environment and so on. The second roadmap that started at the end of 2015, beginning of 2016, has allowed us to see how the fight against poverty actually got traction in a different manner with a sustainable development, all-encompassing holistic view, and also how many other things behind that actually came a reality in the first 5 years. Having said so, with the advent of the coronavirus pandemic, the global roadmap that had started at the beginning of 2016 has decreased in velocity, has been challenged to the utmost because of the pandemic, and particularly has been challenged when it comes to public health. It is, of course, very well known that all the things that we have experimented since perhaps mid-March of 2020, if they have created vulnerabilities and they have affected someone in our societies around the world, is the poorest of the poor, the people that have less access to public health resources, the people that don't have access at all to a government safety net, perhaps, or subsidies, or any type of help. So in this more holistic approach that I wanted to use as an introduction before we get into the issue at hand in digital health inequalities, I would like to invite you simply to think on how we have to build back better when this pandemic decreases or a new vaccine is discovered and administered to the global population. To think about the global fight against poverty in a way that involves you, because it's not only health, it's education, it's infrastructure, it's sustainable transportation, it's the fight against corruption and inequalities and discrimination and the whole. So from the perspective of the United Nations, let me invite you to see the whole, and particularly to see this SDG number 3, to improve health around the world. And we have conceived these 17 goals with some targets under each goal, some specific deliverables that by the year 2030, we will expect that all societies around the world will have achieved. And there is one in particular, 3.8, that says and postulates that we should be achieving universal health coverage, better known as UHC, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. This target 3.8 that we explore a little more in our first webinar last week continues to be valid as an introduction for the conversations that we are having in this webinar series and this speaker series on digital health. And it continues to be valid because if we want to ensure that everyone in a society has actual access to affordable, quality health services, the digital perspective of universal healthcare remains important. And I would like to conclude by telling you that it is important also to analyze and understand a problem looking at the negative statistics, at the status quo. Where are we now? And to do that, we have to focus on inequalities, on the main challenges that we have that create discrimination. Why is it that societies that have good access to the internet and a good level of digital advancement can indeed excel at telemedicine, and countries that don't have those resources and wide internet coverage face this digital divide that even if a capital city offers these resources, then in the end force populations in rural areas mainly or in poor neighborhoods not to have access to. So it's a debate that I am sure that Alessandro and Danny will help us to understand, but it's a debate that should persuade you, I hope, to become part of the solution. We need you, we need everyone watching to learn more about how to engage with the Sustainable Development Goals and Agenda 2030, and particularly on issues of health and public health and digital health. You are invited to be part of the solution. You can contribute, even if it is as a user of digital health, giving feedback, or if you are an expert, as I believe the vast majority of you joining from several countries today are, you can make a difference. So you are invited, and on behalf of UNITAR, again, I thank you for joining us today. With that introduction, I would like now to offer the floor to Dr. Danny Shi, the lead officer in charge of the Digital Health Initiative at UNITAR. Dr. Shi.
Thank you so much, Alex, for your excellent opening remarks. And I'd like to echo you in joining everyone and in welcoming everyone today to this second episode of our Responsible Digital Health series. I'd like to remind all of our participants also to please use the Q&A function on Zoom to submit questions throughout the session, and we will aim to address as many as possible at the end of the discussion. As Alex mentioned, in last week's episode, we looked at the role that digital health has to play in achieving universal health coverage. As Alex has already alluded to, today we'll be tackling the subject of inequities in digital health, an integral challenge to achieving this health for all. In order to frame this conversation, it is important to take a broader look at health inequities, what exactly that means, where they exist, and how might digital health perpetuate, add to, or hopefully help us to overcome some of these inequities. Next slide, please, Julia. According to the World Health Organization, health inequities are systematic differences in health status or in the distribution of health resources between different population groups, arising from social conditions in which people are born, grow, live, work, and age in. These inequities have significant social and economic costs, both to individuals and to societies. And whilst the incidence of some diseases such as tuberculosis are clearly linked to poverty, other diseases which affect all of us, and in some cases have even higher incidence in high-income countries, still disproportionately claim the lives of the world's poorest peoples. Non-communicable diseases pose a significant threat globally, but when we look at premature deaths due to these diseases, we see that in fact 87% of all non-communicable disease deaths occur in low and middle income countries. These inequities lead to shocking disparities in lifespan, with average life expectancy in high income countries nearly 20 years greater than that recorded in low income countries, being 81 and 62 years respectively. However, if you compare case by case in between individual countries, the differences are even starker. With someone born in Sierra Leone, for example, expected to live just an average of 50 years compared to 84 years for someone born in Japan. Next slide, please. Unfortunately, child mortality accounts for a great deal of this overall difference in life expectancy. Even today in 2020, with all the advances modern medicine has made, 16,000 children under the age of 5 die every single day. Under 5s are a shocking 14 times more likely to die if they are born in sub-Saharan Africa compared to the rest of the world. Around the world, poorer children from rural households are much more likely to die, with the poorest 20% of children twice as likely to die as the richest 20%. Next slide, please. Whilst these inequalities are perhaps most noticeable between countries, there are also vast gaps in the level of health provision within countries. This is true in many low-income countries, but also, and perhaps surprisingly to some of you, there are large disparities still between population groups in the most developed and high-income countries. If we take, for example, the United Kingdom, in absolute terms, the inequality of life expectancy has decreased massively in the UK over the last century. However, whilst the gap has narrowed, and of course huge improvements have been made in overall life expectancy, infants of fathers who are unskilled manual labourers have a mortality rate still nearly twice that of infants with fathers who are have professional careers. Whilst in the United States, African Americans represent around 13% of the population, they actually account for nearly half of all new HIV infections, with no genetic or biological factors to explain this phenomenon. And so we start to see here the enormous challenges, but potentially opportunities that digital health has to improve. And it actually does have potentially significant opportunity to reduce the health divide in some scenarios and improve the equity of healthcare delivery. Digital health is not a panacea, however, and interventions are not carefully planned and developed. The advancement of digital health systems may actually worsen the situation and create new additional health inequities, particularly based, for example, on the current uneven distribution of digital health technologies. Without further ado, I would like to introduce my guest for today, Dr. Alessandro Bellissime. Alessandro is a senior scientist at the Swiss Federal Institute of Technology, ETH Zurich. His research and teaching revolve around ethical and governance issues in biomedicine, in particular working on emerging approaches and technologies in medicine with a specific focus on the digital transformation of medicine due to increasing use of big data, mobile devices, and artificial intelligence. Alessandro has a background in philosophy and bioethics, and before joining ETHZ, he held research positions in France at the National Institute for Health and Medical Research, INSERM, at Harvard University and at the University of Zurich. Alessandro, welcome to the series, and thank you very much for taking the time to join us today.
Thank you, Danny. It's my pleasure. Thank you for having me here today.
You're very welcome. Okay, so let me start with the last point I made there in my presentation. Since the majority of digital health interventions rely on at least reasonably modern digital technologies, thinking about smartphones or tablet devices, could you tell us what kind of inequalities currently exist in the distribution of these devices and access to them?
Yes, well, I guess that most of us possess a last generation smartphone, and many will also have other fancy digital tools such as smartwatches or connected appliances at home, or even fully connected cars and so on. And we're broadcasting this event live on Facebook, so we are fully into the cutting edge side of digital innovation here. However, these technologies are so widely distributed today that we tend to give them for granted. No? Probably they don't even look all that fancy anymore, as we got entirely used to them. However, while digital technologies are broadly distributed, not everyone is connected, and not everyone is connected in the same way. So this is a phenomenon that is commonly referred to as a digital divide. First of all, people of different economic means can afford different types of devices, but also different data plans and different connection speed. This is true at the national level, of course, but also across nations. So in some parts of the world, the data infrastructure is less developed than in others, and less people have a smartphone. And what is more, people in different age groups and of different educational background make different use of digital devices. So you may have the latest or most expensive smartphone version, but if you're not familiar with the technology or even with its most advanced features, you may still not be able to fully capitalize on what the technology can do for you, for example, in terms of what the device can do to help you stay healthy. So I'd also like to stress that to the extent that being connected through a digital device entails privacy risks, for example, linked to the collection and distribution of personal data, some users are more alerted than others about such risks and are better at protecting their data. So as far as digital health is concerned, I guess that possessing a smart device is not sufficient to reap the benefits of digital health. You also need to be in a position to turn data into health improvements. And this depends on your own capacity to understand what digital health can do for you, to act consequentially, and also it depends on how well the healthcare systems in which you live develops around digital technology. So systemic elements that we saw in the definition of health inequality are likely to play quite a big role in the way digital technologies can end up contributing to existing health inequalities or level them out.
Great, thank you. And I think we'll definitely come back to the point you made on privacy there and personal data privacy a bit later in the discussion. And I also wanted to focus a bit on the point you made there about different individuals having the capacity to utilize the various potential of their devices. I think companies, big tech companies, even health companies are currently focused so much on getting the most out of a device. We hear the rhetoric so often that so many millions of people have a supercomputer in their pocket these days. So big tech companies are constantly looking at how you can make the most out of that, but it still remains true that a lot of people don't know how to use even the most basic functions that they have available to them. So running before you walk, in a way. I would also like now to move on to the question you made about some of these groups that we identified as being those that don't have access to health as it is, and just thinking about unequal distribution of tech and who are then some of the specific groups that are particularly susceptible to being on the wrong side of this digital divide.
Yeah. Well, I mean, it might be useful to offer like a working definition of digital health, because this, I think it might help us identify who, as you said, might be on the wrong side of the digital device. I think that one of the defining features of digital health has to do with data more than with technology itself. So what looks distinctive about digital health is that it generates a flow of critical medical data between patients, their families, and their physicians or their healthcare staff. So the ambition here looks like generating a circulation of data from patients to devices to health professionals and back to patients. So in this respect, if this characterization of digital health makes any sense, who is on the wrong side of digital divide? Well, I think that at the population level, certainly the poor and the uneducated and even the elders seem to have less to gain from digital health, because they tend to be excluded both from the possibility of having data generated about them and from the possibility of extracting value, health value, out of the information that is routed back to them in this circulation of data that I have described. But certainly there are wrong sides also at country levels. So certainly countries in which digital technologies are less widely available or distributed seem to be more on the wrong side of the divide. But also countries that lack a robust technical and legal, I would stress that, infrastructure for data collection, analysis, distribution, and secure storage. So we're talking about personal data here. So it's important that both the technical and the legal infrastructure is in place in order for this data to be useful from a medical point of view. And this is, I think, part of the story. A lot also depends, in my view, on the way we think about digital health innovation. So there is a tendency in our expert circles to describe digital health as a highly sophisticated form of medicine or healthcare. Some people speak about high performance medicine, and you might think about artificial intelligence algorithms that learn autonomously how to create a diagnosis out of a radiological image, or you can think about algorithms that can infer things like cardiovascular risk from just the scan of of retinal images. This is very exciting, but what are the chances that this kind of progress will make any difference in countries in which healthcare systems are poorly funded and struggle to meet even most basic health needs? So this sounds like harsh criticism, but actually I think that digital health innovation can also be something more than high performance medicine. And many people are working on digital health that offers good prospects for low-cost interventions in less affluent settings. So if you think about the current pandemic crisis, even in low and middle-income countries, people are trying to develop mobile health solutions like symptoms checking apps, or even digital platforms to enable telemedicine, which, by the way, is not only a practical thing to do, it's also something that it's wise to do given the risks that are associated today with physical contact. No? And in a sense, the COVID-19 crisis is pushing on the accelerator of digital health, not so much in its more futuristic, high-performance version, but rather as a sustainable way to respond to the current emergency, both in affluent countries and in the global south. And personally, I'm expecting that these kind of transformations, this kind of digital health solutions will remain after the emergency is over, hopefully soon, of course. I cannot hear you, Danny.
Apologies.
Okay.
Yes, I was just saying I completely agree. Hopefully the outbreak is over soon, and hopefully those impactful interventions that have been made, such as an increase in telemedicine provision, for example, remains. I think also that we have to address the fact that, as you said, in many circumstances, the ethical and legal framework doesn't exist to allow the full adoption of digital health solutions, and even more so in the case of kind of response to an emergency as we're seeing now. You run the risk of putting in place a digital health system before you have the legal and ethical framework in which to secure people's data and secure that what you're doing is ethically and legally sound. So it's kind of a catch-22 situation. We needed to respond to the emergency, but we also have to be aware that digital health is something that takes thought and consideration to ensure it doesn't abuse the data of people and it doesn't disproportionately help some people whilst not helping others. Yeah. Just going back a bit to what leads to some of the inequitable impacts that can be seen in poorly designed digital health solutions. What would you say is the biggest reason currently that leads to inequitable impacts in digital health solutions or digital health interventions?
Yeah, so I mentioned already that unequal access to the network or to digital devices is a major factor, but this is by no means the only factor. Actually, there are a couple of things that could be mentioned here. So in its most sophisticated version, digital health relies on artificial intelligence a lot, and the most widely discussed forms of digital health have to do with artificial intelligence. and especially with a particular form of artificial intelligence that is known as machine learning. Now, the quality of this machine learning system depends on the quality of the data that you use to train the algorithms. So basically the examples that you give to the computer in order to learn how to perform a task, for example, making a diagnosis. Now, if you train your AI with data from patients of a given ethnic background, for example, there is the possibility that your AI will turn out very good at the task it learned for that particular ethnic group, but less good with patients belonging to another ethnic group. Now, to the extent that some human diseases play out differently in different ethnic groups, this is more than just a theoretical possibility, it's actually a real problem. Now, the point is that we know for sure that for at least the last few decades in biomedical research, we have been collecting data mostly from white middle-aged men, which is very biased, of course. For example, existing genetic databases that we use for genome-wide association studies, for example, reflect this kind of bias quite clearly. There are interesting publications about that. Now, if this is the data that we're going to use to train our artificial intelligence, well, we will have to expect that the performance of these systems may vary and even inconsistent way across different human groups. So this is one further determinant of possible inequality. And another important factor that I would mention just in passing is how the healthcare force is willing to embrace digitalization. So we are starting to see that physicians in the global north may have even some unexpected resistances towards digital solutions in health. One example here in Switzerland, for example, is that not every physician is actually very happy with using electronic health records. But in the US, for example, the American Medical Association has issued a very interesting statement on digital innovation in healthcare. And parts of this can be read as raising some doubts on the willingness of the medical community to really embrace digital innovation, especially when it entails a high degree of automation. Now, in low middle income countries, we may see different kinds of bottlenecks, of course, having to do with whether or not the medical workforce and also the other components of the healthcare system are ready to embrace new digital health. So what I think is that we need to study those bottlenecks, what they're likely to be and what can be done to address them. Because if, for example, building digital capacity, I would say, may be a factor determining how quickly digital innovation reaches low middle income countries. Well, on this factor depends the possibility for these countries to reap the benefits of digital health. So I think that there is a lot of research that needs to go in the direction of exploring potential bottlenecks to digital health implementation in low middle income countries. Otherwise, these countries will be by default excluded from the potential benefits of digital health solutions.
Yeah, I think, and that's something that I think isn't often considered. You know, we see a great deal of innovation, but as you say, if it leads to bottlenecks, then the ultimate impact is limited. Just going back to a point you alluded to there as well, and in your last point as well, the case is that often, unfortunately, artificial intelligence algorithms are trained on data that contains some inherent biases.
Yeah.
This may be user error in terms of the person that's designing the AI, but as you mentioned earlier, it may also be just due to the fact that data is not coming in from certain groups of the population due to the lack of access to digital tools. I just wonder if you could expand a bit further, because a lot of us, I imagine, joining will be very familiar with the kind of digital health products that use these kind of AI machine learning algorithms. But if you could just allude a bit further to what kind of interventions are particularly prone to being inequitable and perpetuating these kind of biases.
Yeah. So, well, I mentioned that the input data that you use to train algorithms must be unbiased to the extent possible. But sometimes we're not even aware of existing biases in the data that we collect. So this is not as easy as it might sound. So of course, using existing data collections instead of collecting new data with the explicit intention of creating a representative and unbiased data set is more likely to perpetuate existing inequalities further down the line. But also I think that another important aspect is how you frame digital health more in general. So if we privilege, for example, in terms of research funding, the most futuristic forms of digital health and forego instead digital health interventions that may respond in a sustainable way to the needs of more disadvantaged populations or human groups. Well, in that case, I suspect that this would as well perpetuate existing inequalities or at least leave them as they currently are. So in a sense, it is a matter of teasing out which forms of digital health we think need to be incentivized through specific research funding schemes, for example, because otherwise innovation will, I assume, almost naturally privilege the fanciest forms of digital health. So I think that there is a system of incentives that needs to be put in place in order to make sure that even forms of digital health innovation that are targeted to the needs of the most vulnerable human groups are developed and implemented.
Yeah, and I think, again, unfortunately, we come to a kind of tightrope that we have to walk here, because obviously we have to be innovative as scientists, we have to be innovative as tech entrepreneurs, you know. We have these hackathons seasonally, continuously going on to find the next big AI solution to the biggest health challenges. And I think they're important because it's important to innovate, but the balance has to be struck, and we have to ensure that health impact is given priority over just innovation. You mentioned there obviously already that removing bias from input data is one key step, but maybe you could mention some other key steps that can be taken when planning digital health tools or initiatives to ensure that benefits are more equitable.
Yeah. So yes, reducing bias is definitely paramount. One way of one good example of how this can be done, for example, is the Precision Medicine Initiative in the US. No? So they are trying to address even the issue of potential bias in data by actively sampling an initial cohort of 1 million Americans from all ethnic, geographic, social, and economic backgrounds. And this, I guess, it's like a model that we will need to follow both in medical research and in R&D from now on. But another key factor that I think is very important is offering the public, and by public I mean lay people as well, and patients, but also stakeholders more in general, concrete opportunities for engaging with the governance of research and innovation. And this can be done both in the North and in the South. I mean, we have some history of successful public engagement with science and technology in Europe, but there are also examples of very effective community engagement in low middle income countries that could work as a blueprint. The issue here is that I think we need all stakeholders to have the possibility to shape the research agenda to the extent possible, to discuss what the priorities are, and even to influence the way in which research is conducted or innovation is designed. So if digital health develops inside a bubble, be it an academic bubble or the bubble of R&D departments in either big companies or startups, so if it happens in isolation from the rest of society, and especially in isolation from the social actor that innovation is supposed to serve, well, I think that in that case, it would run the risk of not having the tangible impact that we fancy about at the moment. Because technology is not neutral with respect to values or social ideals. However, if you prevent society from co-producing innovation, chances are that the technology will not serve social need in an efficient way. So we really need to think about technology as an open-ended trajectory and innovation as an open-ended trajectory. And instead, I think that we very frequently are still, we still encounter deterministic accounts of innovation, in accounts that present innovation as imminent or inevitable, unavoidable, and not modifiable. I think we need to get rid of these ways of thinking about technology if our aim is a kind of technological progress that benefits different human groups across the population and at the international level as well. And I think this is particularly important when human health is at stake, of course, and some governance models have emerged over the last few years that try to implement this different way of thinking about technological development, technological progress. And I'm thinking about responsible research and innovation that applies across the board, so to innovation in all fields. Here in Zurich, we're trying to work ourselves on innovative forms of governance that would increase opportunities for social engagement with both the design and the governance itself in digital health. So I think that this is important. We need more voices to be heard. We need to regularly collect information and input from stakeholders and listening to what society expects innovation to do for it.
Yeah, completely agree. And I think this component of involving the populations, involving the public from the start really helps to encourage their buy-in. And I think, we've seen in recent years the increase in citizen science and the success of citizen science as well. And I think involving the public in the collection of data, in the building, in the design of digital health tools, making sure that interventions are patient-centric really helps them to succeed in the long term. I'm going to switch gears slightly now and talk about sort of personal versus private, personal gain versus societal good. In some cases, digital health interventions can be inequitable on an individual level or demand more investment from certain groups or certain people, but overall have a positive public health impact. What are the ethical implications with this kind of issue? Is it okay for public health benefit to trump individual disparities? Only sometimes? If so, when is it okay? And I think it's particularly prudent to talk about this now at a time when we're all suffering from the same thing. So.
Yeah, exactly. I think that your question makes me think of the current situation. So think about one digital technology that is being employed these days to fight against coronavirus. It's digital contact tracing apps. A lot of governments have rolled out national digital contact tracing apps in an effort to boost more conventional forms of contact tracing, of course. So it is clear that in the case of these kind of apps, younger generations are more likely to download the apps. And there are clear sociological data that are starting to emerge, and they show this pattern very, very clearly. The younger you are, up to a certain point, the more likely you are to download and actually use these kind of apps. So you might say that the younger generations bear a bigger part, a bigger share of any privacy-related risk that goes with those apps. No? So you might say that by downloading the apps more than the generations of their grandparents, they bear more privacy-related risks. However, I think that we are in a situation in which we need to shift gears really in our thinking about even the ethical implications of digital health in this case. Because we need to factor in values like solidarity if we want to really defeat this enemy. As you rightly put it, we are together in this fight against COVID-19. We are together across generations, across nations. Okay, sometimes we might see countries going their own ways, but I think that there is an important lesson that we are learning with COVID-19, and quite unfortunately we're learning it the hard way, that the lesson is that in some circumstances like the present one, our individual health is tightly linked to the health of our fellow citizens, of our fellow human beings. So health is clearly a communitarian thing, at least through the lenses of the COVID-19 crisis. This is a public health crisis, and we will only win if we never lose sight of this feature. So we really need to act as a community here. If some burdens or risks are not equally distributed, we should know about it. We should try to minimize the consequences that this might have at the individual level, but we cannot forget that some sacrifices might be required for the greater benefit of all, for the greater good of all. So I think that here we are learning that even the ethical language that we have, that is pretty well developed in the field of biomedicine, needs to be enriched with ethical language that comes from public health ethics, and this might justify some unequal distribution of the burden of being traceable, for example.
Yeah, absolutely, completely agree. And just in the interest of time, Alessandro, and sticking to our allotted time, I'll ask you my final question now, and then I will turn to some of the questions posed by our participants today. So my closing question to you is, how do you see the future of digital health advancing in a way that helps to achieve equitable health impacts for all?
Yeah.
An easy question, sorry.
Yes, you know, every new technological development is sort of an adventure in the sense that it's really hard to predict how things will go. So I think, however, that in the short to medium term, we will start seeing what digital health solutions will really look like, and we will become more able to distinguish hype from real progress. So health equality that you described at the beginning is something that it's not something that a given technology can naturally serve. So we need to really increase our capacity to steer innovation into socially desirable directions. Otherwise, it won't happen just in and of itself. So if we want digital health to advance equality in health, we need to intervene. We need to develop further our capacity to intervene. And this is a matter of governance, no? and incentives, as I was saying earlier. So I think that there is a lot more than we can do in this space. The good news is the conversation is ongoing, and there is still room for for change. There is still room for steering the innovation pipeline into the direction of more equitable distribution of health and health opportunities, and more a more equitable distribution of health outcomes in the end. So I would like to stress, though, that health inequality refers to systematic differences in health status, now across different populations or across different human groups. So, in a sense, we know that we can intervene by technological means, but technology can help at the downstream end of things. It cannot fix what is wrong upstream. It cannot fix what is wrong in our society, in the structure of our society that generates patterns of social exclusion and systematic economic disadvantage, for example. So if we remain mindful also of the limits of technology, I think that we are in a better position to really reap the benefits of what technology can do, and with more targeted interventions. So technology is not going to fix health inequality, because according to the WHO definition that you provided, health inequality depends on structural features of society. But it can help out downstream of where these patterns of social exclusion and disadvantage are generated. And I think that there is a lot of room for improvement there, especially in my view, as to how digital health technologies can contribute to the goals of health promotion in low middle income countries. I think that this is something I would definitely want to see more engagement with, and I think that there is really a potential for digital health promotion to result in some concrete benefit for human communities in low middle income countries.
Absolutely, I think that's the message really. Digital health and digital health tools can be important for helping fix some of the systemic inequalities that do unfortunately exist and do unfortunately perpetuate. And perhaps, yes, from a health promotion is one of the biggest ways in which we can achieve the bridging of those gaps. So I will just try and answer a couple of the audience questions here with you, if that's okay. First one here is, what does community engagement with data governance look like when introducing digital health interventions?
So this, I could answer this question in two ways. So at the level of developing digital health tools, I think that community engagement might happen upstream, might happen very early on. So you can have you can have social science interventions in the communities that are going to be targeted by the technology. For example, you can have focus groups or deliberative forums in which you call for the input of the target community into the design of the technology. And this is particularly likely to go well if the development of the technology entails data collection. We have evidence from decades of experience, for example, with the creation of population genetics biobanks, that whenever you try to sample a given population, the community is very actively willing to have a say and to participate and to co-design. On the other end, you could address community engagement at the implementation phase. So if you have if you are about to deploy A given digital health intervention in a community, I don't know, for example, in a urban community in sub-Saharan Africa, I think that what can be done, and it's important that this is carefully staged. What can be done is to try to understand what are the users' perspectives on the technology. So what are the impediments that do not allow everybody to gain from the use of the technology? Where is that the technology encounters a firewall? Where is that the technology fails to respond to the expectations of the users? So there is a lot that can be done in collecting data on the ground from the users and adapting the design of the technology to the information that you gain from the users. So this is more resemblant of the adaptive governance model that we have been working on, and yeah, has a huge pedigree in science policy.
Great. Next question we have is regarding gender and inequality. So is there gender components in the potential inequalities of digital health interventions? I guess thinking here about bias in data, but also in terms of users and the disparity between genders in the use and uptake and literacy, digital literacy.
Yeah, well, I think that this has, of course, yes, bias so let's say defects in representativeness of data sets is something that affects women a lot, potentially. But the point is this: we know that gender is an important determinant of health. We know it from public health research. It appears that whatever social economic determinant of health that we know about is likely to have a role also in the digital domain. So social determinants of health over the course of the last few decades have shown an impressive robustness. So they are robust across different domains. In other words, what creates a disadvantage in one domain is likely to create a disadvantage in another domain. And as far as social determinants of health are concerned, we know pretty consistently that social determinants are robust across a wide spectrum of possible human activities. So this means that to the extent that gender is a major determinant of health, and in some settings it's definitely a cause of inequality, this is likely to be the same in the domain of digital health. So I think that we need to be aware of the fact that the social determinants of health are robust enough to play out with equal magnitude in different contexts, and this is why it's urgent to address them.
Absolutely, I 100% agree. And I think we have time for just one more question. We've gone over a little bit, but I think it's okay. The last question is, how can inequities in digital be measured reliably?
That's an excellent question, and one for which I don't have a ready-made answer, because the studies of inequalities in the digital domain, inequalities play out in the health of people, are just starting to emerge. I've seen efforts at measuring, let's say, digital divide across nations. So there are indexes that are starting to appear that try to rank countries as to their readiness to embrace digital health. let's say, the digital transformation of healthcare and medicine. And these are, to my knowledge, this is the state of the art of this attempt at measuring the inequalities in digital health. The results are quite surprising because, okay, there are some countries that you would expect to rank very high as countries that are pretty ready to embrace digital health, but it's surprising to see that per capita income, for example, is not alone a good predictor of a country's readiness to embrace innovation in this domain. It's a complex ecosystem that needs to be in place for digital health to happen, and not many countries are fully ready for that. I don't know if this answers the question. Maybe it goes in the direction of the question.
Yeah, I think so. I think that's definitely the way forward is this kind of self-assessment. And I've seen that there's a number of kind of self-assessment tools for governments, for countries to look at themselves and say, are they ready? Obviously, it kind of depends on where that question is coming from. There's obviously a precedent to say you're doing better than you are in some cases, particularly in high-income countries, as you say, they may not be reflective of the actual situation. But I think given the disparities that exist within countries and within population groups in a country, I think having a kind of self-assessment tool is kind of the easiest way to go about doing that. So I'd like to wrap up there, and thank you again, Dr. Blessine, for joining us this afternoon, and thank you to all the participants. Thank you to Mr. Alex Mecha for giving the opening remarks, and to Ms. Julia Gent for her help in logistical support as well. Please join us again next week for a session on digital health during pandemics, and don't forget that this is part of a 7-episode series. We're on episode 2 now, so hopefully you'll come back for the rest of the series as well. And I wish you a very pleasant day, and goodbye from UNITA.
Thank you, Danny. Thank you. Bye-bye.
Thank you. Bye-bye.